Dr. Dan Staso is our presenter today, and he's a licensed psychologist in full-time private practice, and he owns the Santa Barbara Brain Fitness Center. He wrote his doctoral thesis on biofeedback and has taught at both the undergraduate and graduate levels. For the past 16 years, he has specialized in biofeedback and neurofeedback in Santa Barbara. Please join me in welcoming him this afternoon.
Perfect. So the title of my talk today is From TBI to Peak Performance, the Diverse Applications of Neurofeedback. I wrote my doctoral thesis on biofeedback. That was because I wanted a thesis that was short, that was easy to do, and I found that hard data works really well. And so it took me a fairly short period of time to get through it, but that opened up my interest in this field of self-regulation. Licensed now for about 35 years. I got interested really in 1983. I'll tell you a short story about Margaret Ayres in just a minute. Bought my first alpha theta trainer at the Miniature Clinic in 1991 and bought a Neural Pathways in 2001. Since that time, I've gone through 10 different systems, not because I have ADD, but because I'm very curious and I'm always trying to find the best system available for people. So I want to try to give you just a kind of I got a little video for you to watch. Just give a basic introduction to neurofeedback. This is about 4 minutes long.
Hi, this is Mike Cohen. I first took my dad to neurofeedback in 1995. He was struggling with severe agitation. We went to top doctors, nothing worked. Then we found neurofeedback and the effect on him was remarkable. Ever since, I've worked with neurofeedback. So when people ask, what is neurofeedback? They typically want to know how you do it, what it helps, and how it's different than other options. With neurofeedback, anyone can improve their brain. We've trained children, teenagers, and adults from age 2 to 92. For children, it's often used for ADHD, emotional and behavioral issues, learning and developmental delays, and struggles in school. For adults, it's commonly used for anxiety, depression, obsessing, and sleep problems. Neurofeedback measures brain activity, like brain waves, and it helps you make more or less of certain brain patterns. By changing brain activity, or by changing how one area of the brain talks to another, you can improve attention, control of your emotions, and behavior. There's research on how it helps migraines, pain, concussions, addiction, and seizures. But what do all these have in common? They're brain issues. With neurofeedback, your brain changes itself. And when it does, typically any of these issues improve. It's not all about problems. Neurofeedback improves performance by changing the timing of the brain. That can help anyone in performing in school, business, or sports. It helps give you an edge. Neurofeedback is different from brain games like Lumosity or tutoring or therapy. Those focus on changing your skills or behavior or how you think. Neurofeedback is focused on changing the brain. There are parts of your brain that help you pay attention, that help you be calm, that help manage your mood and your emotions, or that help you sleep. You don't realize how much your brain affects your mind. With neurofeedback, you get to see how changing your brain can have a huge impact on your life. How do you do neurofeedback? First, we put sensors on your head. Commonly, we measure your EEG brain activity with a special computerized system. The system gives you feedback, such as playing a movie or hearing a beep. For example, when you make a certain amount of beta brain waves, the movie will play perfectly. But as soon as you're less alert and awake, the movie starts to fade out. You rapidly learn how to keep the movie from fading out by changing the brain activity that's being trained. Your brain has a way of figuring out how to get the movie to play. Once you learn new patterns, and that may take practice, your brain tends to remember it. There's a lot of published research that shows that the brain learns from feedback and that measurable changes in brain activity occur after training. So how do you change your brain? It's just learning. Children learn to play a video game, and they never read a manual. Their brain figures it out. How do you balance on a bike and not fall over? Somebody probably showed you, but it's your brain that figured out how to balance. When you train brain activity, your brain figures out how to balance its own activity. So once you train the brain, does it stick? Well, you don't forget how to ride a bike, even if you hadn't ridden in 10 years. It's the same with neurofeedback. Once your brain learns, you don't tend to forget it. There are exceptions, particularly if there's disease like Alzheimer's or neurological issues, but there are still ways to train your brain. The changes you make with neurofeedback can over time have a profound effect on learning, memory, attention, mood, migraines, and far more. If you or someone you know could benefit from improving their brain, we encourage you to learn more.
Okay, that's neurofeedback in a nutshell. Any questions? In 1983, I was working in a psychiatric facility, psychiatric hospital, working with the medical director, and I also had a former supervisor who said to me one day, he says, you know, all these kids that are in the hospital who have learning disabilities and ADD, I know somebody who fixes that. And I said, I don't believe you because even though you're my supervisor, I never heard of this. At the time, there was no internet, so I couldn't really do any research on it. I had done my thesis in biofeedback, but at that time, you had to go to the library and find exactly the article that you're looking for. So I sort of ignored it. And then a case I had referral was a woman who had a stroke. 7 years prior, she had mild verbal apraxia. She had word retrieval problems. She would be sitting in front of me saying, Doc, you know, last night I was watching that thing that has wires in it. I said, television? And she would say, yes. And then she would fan herself. She had high anxiety, and I did my best to help her, but it occurred to me that maybe this woman called Margaret Ayers might help. And so I referred my first case to her based upon these symptoms. And to my absolute amazement, all of her symptoms went away. Her anxiety went away, she became more verbal, and her word retrieval problem basically disappeared. So that was encouraging. So I thought, well, if we can work with that, maybe she can work with this case. It's the case of a 23-year-old man who had 8 psychiatric admissions in 6 years. 6 of those were in 5150s. He'd had a head injury at age 17 when he was hang gliding with no helmet and crashed into the rocks in Palos Verdes. He had poor impulse control, poor judgment, bizarre behavior, violence, grandiosity, impulsiveness, and lack of insight. He had just been every diagnosis in the book. Nobody could really fix this kid. And after a failure to get conservatorship, I said to the family, well, maybe you should try this woman in Beverly Hills. And again, to my amazement, he got better. He was never rehospitalized. I did a 2-year follow-up on this case. Never rehospitalized, got a girlfriend, went back to work for the family business. Because he had no symptoms prior to the age of 17, had no history of any behavioral problems. The third case was Ralph. I referred to her. He came in to see me for couples counseling. He was very rigid, very successful businessman in sales. And he had very rigid thinking, suspicious of his wife, quick to anger, never felt relaxed, depression 2 days a week. And the problem was every time his wife was nice to him, he would think that she was up to no good and be suspicious of her. I did a year of CBT with him, almost entirely just with him. I separated the couple. Turned out that he had had a major car accident at age 18 where he was hospitalized for 3 months. So of course, I referred to neurofeedback. All of these symptoms resolved. Rigid thinking, suspiciousness, his anger resolved, depression went away. And I saw him for about 6 months after that, and he had all these amazing insights that came to him that were basically paraphrasing what I had told him the first 12 months of therapy. So I became a believer in neurofeedback and referred to Margaret Ayers for 17 years until she convinced me to buy one of her machines in 2001. Neurofeedback is biofeedback would be considered doing anything neck and below, and neurofeedback would be the neck and above. But it follows the same principles. This is the official definition of biofeedback. It's a process that enables an individual to learn how to change physiological activity for the purposes of improving health and performance. Precise instruments measure physiological activity, such as brain waves, heart function, breathing, muscle activity, and skin temperature. These instruments rapidly and accurately feed back information to the user. The presentation of this information, often in conjunction with changes in thinking, emotions, and behavior, supports desired physiological changes. Over time, these changes can endure without continued use of the instrument. Now, I have a full-feature biofeedback system in my office, Thought Technology. And the common modalities are EMG for the muscles, temperature, heart rate variability, respiration, skin conductance, and of course the brainwave. Neurofeedback is training the electrical activity and the timing of the brain directed towards either normalization of neurophysiological functioning or psychological integration. These are peer-reviewed studies. In the last 10 years, I think we've had 1,400 studies that come out now on neurofeedback. So if anybody says there's no research, doesn't exist, that's not true. They just haven't looked very far. So you'll find it on depression, anxiety and panic attacks, OCD, PTSD, addictions, ADHD, learning disabilities, head injury, stroke, coma, chronic fatigue, fibromyalgia, epilepsy, and headache. Other conditions you'll find improvements in autism, PMS, bipolar disorder, Asperger's, chronic pain, reactive attachment disorder, and peak performance. Let me talk briefly about brain waves. Here's what I do in the office. Quite commonly, I'll put sensors in the scalp, and it goes into an amplifier, it goes into my software, and it separates it out into different frequency bands. Initially, you see all the frequency bands, everything together, and you can sort these out. The delta waves, normally you're going to find delta is dominant in the brain when you're asleep. When you're awake, you should have very little delta in your brain. If you have a closed head injury, you're going to have delta. You're going to find it in brain maps, also late-stage Alzheimer's. Sometimes you'll find it in cognitive deficits from bypass surgery if you have a long anesthesia for surgery. A high amplitude of delta awake interferes with emotional and cognitive processing. Theta waves. When you start falling asleep at night or waking up in the morning, everybody goes through a dominant theta wave frequencies. This is where you are pre-sleep, daydreaming, visualization. However, if you have too much of that in the daytime, it's associated with not paying attention and being distractible. So I'll be watching all of you to see if you go into theta waves. Alpha. Alpha is produced when your eyes are closed, mostly in the back of the head. If you find a lot of alpha in the frontal lobes of the brain, that's consistent with ADD, quite commonly. And if you find it in the left frontal higher than the right side, that's a marker for depression. Also correlated with IQ. When you're young, say you're 23 or 24 years old, just got out of college with your master's degree, your peak alpha frequency might be a 10.5. As you progress through life, it starts to slow down. If you get into Alzheimer's, it might be an 8.5. So most of the people I test are in the 9s and the 10s. SMR, 12 to 15 hertz. This is always, you'll find this on the motor strip, and it inhibits your motor activity. It's been used to regulate impulsivity and hyperactivity, training that up on the right-hand side. Beta waves, you and I should be in beta waves right now, 15 to 20 hertz. This is your complex cognitive functioning, your reading, your listening, active external attention. So if we're in this, your frequency, you should have good concentration, good focus, and good attention. Now, sometimes people have too much of a good thing, they go a little higher. So if you're in beta, what's called high beta, 22 to 36 hertz, that's characteristic of anxiety disorder. Your body's going to be tense, high state of arousal, you're going to be stressed. And then gamma, I don't work too much with that, typically in the frontal lobe. Memory consolidation, complex learning, difficult to train. It comes in bursts. This is considered the frequency your brain organizes things. I like to say this, that traditionally in mental health, we've got two choices. Either somebody's going to be referred to talk therapy, psychotherapy, or you're going to get medications, or you're going to get a combination of those two. I'm proposing that neurofeedback is the third leg of mental health. It's the third option. Now, of course, you can do talk therapy and neurofeedback. Oftentimes, when a person is doing neurofeedback and medications, they can continue on medications, but oftentimes a person requires less and less medication as time goes on. That's why it's important to be monitoring that. Neurofeedback avoids mental health stigma. It's non-invasive, mostly non-talk. I'm a psychologist, I always talk to my clients all the time. But for some individuals, like teenage boys, sometimes they will refuse talk therapy, but they're okay to come to see somebody like me, and I show them video games, or I show them movies, and we don't talk very much, and they make progress. Oppositional defiant disorder resolves pretty easily in this. So neurofeedback, I put the sensors on the scalp again, I amplify it, raw data in the software. Clinician determines the frequency to reward, threshold about 65 to 85%. You can watch video games, listen to music, watch movies. Typically recommended once or twice a week. Oftentimes it's recommended twice the first week or two, and then slowly tapering down to once a week. And then beyond that, once every 2 weeks, once a month. 30 minutes of feedback. Usually effects will be noticed between the first and the 8th session. 20 to 40 sessions depending upon your equipment and the type of problem. In the practice that I have, most of my clients will notice something within the first 6. If they're not doing 12, then I reassess what's going on and determine if that's the right machine for them or if they need something else besides neurofeedback. Forgive the oldness of this photo. I realized too late that I have not taken a new picture of what's going on in my office. But this is one of the softwares that I use called Signet. And you can see that there's a video game that she's watching, and the cars are moving forward. Early research. 1929, Hans Berger initially discovered the alpha waves. 1963, Joe Kaima, University of Chicago, trained students to increase the alpha waves. And his work in alpha waves took all the neurofeedback and the low frequency training, sort of meditation approach. Barry Sturman, 1968, did SMR training, university stuff. Roots are in behaviorism and operant conditioning. You remember Pavlov, B.F. Skinner, and Neil Miller, teaching animals to alter autonomic nervous system functioning. The autonomic nervous system is supposed to be something that's automatic. You're not supposed to be able to regulate it. But we know we can do that. First major neurofeedback study was done with cats. Barry Sturman. I don't know how he got this idea, but he noticed that when cats were just sitting there doing nothing, just sort of waiting for a mouse to come by, the predominant frequency of EEG was SMR, 12 to 15 cycles per second. So he thought, well, what if I give cats some milk every time they did this SMR? Could I increase the SMR in the cats? The answer was yes, resoundingly yes. He published that study in 1967. Then he got a government contract to study rocket fuel. People, I think it was the astronauts, were having seizures, smelling this rocket fuel. So he exposed this rocket fuel to all these cats. And he found the cats had seizures, except for some of these cats didn't have seizures, and one cat didn't have seizure regardless of how much you exposed the rocket fuel. So he scratched his head, so what's up here? One of his lab assistants says, you know, these are the same cats that you did the SMR study on. Maybe there's something about training SMR and seizures. So I think the story was one of his lab assistants had a seizure disorder, and she had fallen off a horse when she was young. And he tried it on her, and she became completely seizure-free and got off her medications. That was an amazing start. So he started studying seizure disorders. He changed his whole focus from cats to humans. And his studies showed a decrease in seizure severity and frequency with SMR training, usually it's on the right side, 12 to 15 hertz. However, patients with seizure disorders who also had ADD also showed an improvement with ADD. This led to studies of Joe Lubar, University of Tennessee. He thought, well, let me take this technology and start applying it with my focus on ADD. He found in his study with 1,000 children, 80% effectiveness, just using this very simple protocol. And I think he extended it to the theta-beta ratio, which I'll talk about. Average increase in grade level in standardized tests was 2.5 years. Typical increase in IQ test scores range from 8 to 19 points. Average grade point average improved 1.5 levels. 60% decrease or elimination of medication. Major improvements in behavior. Later studies show these gains were permanent. Now this was done in the 1980s. Barry Sturman was all excited, got a National Institute of Health funding in 1982 to study neurofeedback with seizure disorders. He thought, now I'm going to show the world this training works. In the middle of the study, the funds got canceled. There was no explanation as to why the study money got canceled. And despite repeated attempts to get more funding for neurofeedback, there was no funding for 26 years. This is why it took things so long for neurofeedback to sort of catch up, or for the world to catch up to what neurofeedback is doing. It wasn't until 2008 that we got funding, government funding for ADD. Margaret Ayers was a student of Barry Sturman. She opened her first clinical practice in 1975, despite the fact Barry was not very happy with that. She expanded her work to depression, TBI, anxiety, OCD, stroke, etc. She founded Neuropathways company and trained hundreds of people, including me. The Othmers, Siegfried and Sue Othmer, had seizure epileptic son, successfully trained by Margaret Ayers in 1985. They founded a company, and they've trained more than anybody else. There's 17 now, as I speak, at least 17 different ways of doing neurofeedback. The field has really expanded and grown tremendously. It's quite complicated, but fun and interesting. What I do a clinical interview, symptom checklist, sometimes a brain map, and I do a progress review. There's lots of different kinds of brain mapping you can do. There's the QEEG. That's 19 channel. It's a red cap. You put it on the head, and you collect the data and send it to a normative database, typically NeuroGuide, which has, I think, a subset of 650 subjects. And Loretta is an advancement of that. You can do, let me show you a brief sample of that, if I can. Here's a sample of a QEEG. I'll show you one that's a real simple one. This is a person who had a TBI. He was skating with no helmet and fell right here on the right side of his frontal lobe. And he had vertigo. He doesn't think as well. So if you scroll down on this, this is what a sample EEG report looks like, the full 19 channel. You can look at every single channel. This is the Loretta. It looks like an X-ray, but it isn't. It's a mathematical formulation that shows the origins of the source of the problem, which can lead you to do what's called a Z-score training. And Z-score is you find plus or minus 2 or 3 standard deviations from the mean, and you train the brain to go to the mean. A very effective protocol. Scrolling down real fast, you'll see these maps. This is the absolute power Laplacian. Again, it doesn't always look this good, this clean, but you can see here is the delta in the right frontal lobe where he got injured. So it shows up on this map. Doesn't always show up nice and clean, but I thought I would show you one that's really simple. So again, for head injury, you find typically a lot of delta in the brain. This is where you found it. So the training would be to bring this into plus or minus, actually pretty close to plus or minus 1 standard deviation would be the protocol that you'd use for that. There are other maps. This is five sites in the head. It goes a lot faster, a lot cheaper. This is the Swingle Clinical Q. Paul Swingle is a clinician in Canada, is the largest neurofeedback clinic in North America. And what he does mostly is these 6 areas of the brain, and believes that for most clients, unless they come in with a sort of a classic TBI or seizure disorder, you don't really need to do the full brain map. It's just his opinion. And here you can, you look at the top of the head. One of the things you look for ADD is the theta-beta ratio, the very top of the head. If you're 2.5, here is 2.2, you're supposed to probe for common attention deficit disorder. So looking at the theta-beta ratio is one of the indicators for ADD, and one of the training methods is to shift that ratio so that your beta is a little bit is higher and your theta is a bit lower. Change that ratio to less than 2.2. And that works quite well at the very top of the head. And the reason being is if you and I were trying to concentrate on something that was interesting, we would be able to get that beta going and downtrain and push down that theta pretty easily. If you're working at something that's not so interesting, you have to work a little harder to focus your attention. But you can master it if you don't have ADD. If you have ADD, when you're focusing on something that's not interesting to you, what happens is you have no control over it. The theta starts to burst up and your beta goes down, and you start to daydreaming, just like that. And the harder you try, the more the theta goes up. So it's not a pleasant state of being. So anyway, that's trainable. You teach the brain how to change that ratio. Quickly, Sutar brain map. He does a full 19 channel. His has something that's very easy to read. You see these little meters. It goes to the right and to the left. And it gives the clinician an idea about what to train. And you can do a pre and a post. You can see measures, sort of hard data to work with. And the last one is the TLC. You also do 19 channels. It's not compared to a normative database, it's compared to the research literature. Swingle compares this to a clinical database. So there's all different kinds of ways to collect data. And the one I'm commonly using now is the lens. I do a brain map, and it shows me which areas to train next. So there's lots of different ways of collecting data. The QEEG objectively and scientifically evaluates a person's brainwave function. It takes a long time. It takes anywhere from 60 minutes to an hour. Clinicians' time is at least an hour and a half. Now, I don't want to confuse you, but there's all different kinds of ways to train the brain. You can do 1 channel, do 2 channels at the same time. You can do 4 channels. Some people train 19 channels simultaneously. Some people do interhemispheric and Z-score. Z-score I talked about, training the brain to go into plus or minus 1 standard deviation. The interhemispheric is the Othmer's design, where they put typically at T3, T4, and they asked you every couple of minutes as they change the frequency, how does it feel? And the idea is to get you in real time to the frequency where your brain is the most alert and your body is the most relaxed. Because if you train the brain too high, you'll be very alert, but you'll be tense at the same time. If you train the brain too low, you'll be very mellow and relaxed, but your brain is a little foggy. So the idea is to try to find that little sweet spot. Then there's what's called non-traditional methods. The lens is considered non-traditional. Neurofield is becoming more traditional. Neuroptimal and HEG. The lens, which I use, is a passive form of neurofeedback. What I like about this is a person can be squirming at the same time. They may not really have the interest in doing the neurofeedback. I'd use a very tiny, tiny microcurrent. The feedback is adjusted 16 times a second to the offset, the dominant frequency. Commonly produces results faster than traditional neurofeedback. It's been my goal, going through 16 years and 10 systems, to try to find a system that's reliable, that's smooth, that's not too expensive, although all these systems are pretty expensive. Keep my costs fairly low to my clients, and that works really fast. So you can use it with very young children. You can use it with individuals less motivated, and those who do not have the impulse control or stamina required to do other neurofeedback approaches. The lens works extremely well for TBI. It tends to work very fast with under 10 sessions for most clients. I was trying to find a system that was as good as the Margaret Ayres for TBI. I think I found one. The lens also works with fibromyalgia, anger episodes, restless leg, anxiety, depression, insomnia. And what was another interesting selling point for me is you can use it for animals. It's used with horses, cats, and dogs. You can modify their behavior in a good way. I'll show you the map. Here's the classic placement sites that neurofeedback clinicians use. It's called the 10-20 system. Each one is labeled and numbered. So if you're talking to any neurofeedback practitioner anywhere in the world, you say, I put the sensor at F3, they know exactly what you're talking about. And so from top down. So everybody in the field uses this configuration. Sample of the clinician screen, client screen. Oh, let me show you just a short demo of. So one of my screens in thought technology. For SMR training, what I do is I say, fly through that O-ring. So you have to focus your attention and concentrate. So the more you are suppressing SMR, increasing SMR, the more accurate you are, and you get points as you go through it. And I can change that bird to anyone of different airplanes or a huge monster, whatever they like. And then they have to score a number of points in order to get the next airplane or the next thing up. And I reward them a lot, saying good job, and I give them coins at the end. So this is a basic SMR training screen that I use. But you can use it for peak alpha frequency, you can use it for lots of different things. It's a standard. So for treatment protocols, the most widely used treatment protocol is SMR, 12 to 15 hertz, inhibiting 4 to 7, inhibiting beta. So you're asking the person to fly through that O-ring as the brain targets this one frequency and downtrains the other. You can't have these other two going at the same time. You isolate this one frequency. Typically for traditional neurofeedback, it's 30 to 40 sessions. You start seeing changes between 10 and 20. It meets the criteria for efficacious and specific. It's believed to reactivate the default mode network, greater internal reflection, greater memory consolidation. It's a meta-analysis. It is considered efficacious and specific. October 2012, the American Academy of Pediatrics elevated neurofeedback to the highest level of evidence base for the treatment of ADHD. It's level 1 best support. So those are a major plus for neurofeedback. For depression, lots of ways of treating depression. A very common way of treating depression, but the placement right here on F3, reward 14 to 18 hertz, inhibit the 8 to 12 and 5 to 7. So working with the left frontal In general, the left frontal lobe of the brain is approaching. You want to approach the things that you do want. The right frontal lobe is more of your avoidance. You're moving away from what you do not want. A healthy brain has a nice balance between these two. If you get depressed, this area of the brain tends to shut down. So you're no longer approaching what you do want. This is more activated, so you start avoiding things. And so when you're depressed, you start backing away from your life. You're not doing what you would normally do. And most of your positive emotions are over here. Most of your negative are over here. So you're basically, the lights are dimming in the area of your brain that have the positive thoughts. A common placement for anxiety is top of the head, rewarding 11 to 13 or 13 to 15. Anxiety remits in 10 to 20 sessions for most clients if you just did that. Now some anxiety is in the back of the head. You have high beta in the back of the head. And of course with the brain map you could customize it even further. Traumatic brain injury appears to improve memory in persons. Neurofeedback with brain injury improves attention and performance, accurate performance tasks, decreases errors in problem-solving tasks. These are the studies. The person I like a lot is Mary Lee Esty. 2015, her and partner Nelson did a study on TBI symptoms and PTSD in war veterans. And she used a version of the lens that I use. And she demonstrated that in less than 10 sessions, these symptoms remit almost entirely. She got a government study. Yeah, this is where I move the sensors around to follow the brain map of the lens. That's where the microcurrent stimulation. Traditionally, physical medicine and rehabilitation physicians tell head injury patients that 1.5 years after TBI, they cannot expect further improvements and must simply adjust to their deficits. Neurofeedback evidence shows this may not be the case. In fact, it really isn't the case. Bipolar disorder is a person in North Carolina published a study with 40 patients with bipolar. They did interhemispheric. They found the frequency 11 to 14 or 13 to 16. In his study, all of his patients were able to significantly stabilize mood, improve functioning, while decreasing or eliminating medications. I'm going over these studies to sort of point out that this has a tremendous potential for integrating it into traditional mental health. Insomnia is something that is fairly easy to fix with neurofeedback. SMR training for most people will do the job. Seizure, the meta-analysis of 25 years of published research, 63 studies, shows that 1/3 of seizure patients do not benefit from medical treatment. All the studies reported an overall mean decreased seizure incidence involving treatment in 64 out of 87 patients, 74%. Asperger's has been shown to help with that. There's a Thompson in Canada. They did that study with 150 Asperger's syndrome patients. 40 to 60 sessions of neurofeedback with biofeedback. Improved attention, impulsivity, auditory, visual attention, reading, spelling. If you combine neurofeedback with HEG, one study found 42% reduction in overall autistic symptoms. Briefly, chemo brain, there was a study that was done. Some people who have chemotherapy end up with fogginess of thought, cognitive challenges, memory challenges. Some have sleep impairment, fatigue, anxiety, and depression. It's a study done by Alvarez in 2011. Showed significant improvement after 20 sessions of neurofeedback. Depression improved, cognitive functioning improved. Addictions. Some of you may know that neurofeedback is starting to be adopted finally in addictive programs. In 1990, the study came out by Peniston and Kukulski. They found what they did was alpha theta training the back of the head with some biofeedback and imagery, and it was a part of a 30-day program. And they found at the end that there was an 80% rate of recovery in their control study. That's been replicated several times. So there's 60% fewer relapses after 4 years, 30% develop an aversion to alcohol. Scott and Kaiser added beta training to actually improve the rate. Criminal justice, 2 million people are currently reside in prisons and jails. I've gotten different estimates on the percentage of adults who have at least one TBI. I just used this one. The estimated 60% of adults who are in prison have TBIs, compared to 8.5% in the general population. And those are people who report having a TBI. If you go to the Amen Clinic and they do their assessment, they ask you 7 times, have you had any head injuries? Because a lot of people forget they've had head injuries. Prisoners who have had TBIs often have severe depression, anxiety, substance abuse disorders, difficulty controlling anger and suicidal thoughts and or attempts. Among male prisoners, a history of TBI is strongly associated with domestic and other kinds of violence. Children and teenagers who've been convicted of crime are more likely to have had pre-crime TBI or other sorts of physical abuse. Homelessness has been found to be related to both head injury and prior imprisonment. The most famous study is this guy, Douglas Quirk, who spent his career working as a psychologist in Canada at the Ontario Correctional Institute. And he had this theory that certain types of violence originated in an epileptic burst in the deep part of the brain. So what he did was he took 77 convicts who he thought classified or would fit in this category. They gave him GSR, Gavin skin response, biofeedback, and SMR training from 0 to 34 sessions. He did a follow-up study 18 months post-release from prison. Those who had less than 4 sessions had a 65% rate of rearrests, and those who went through the whole treatment of 34 had a 20% rate of recidivism. So neurofeedback makes a huge difference for TBI in the prison population. Quickly switching over to sports. The Italian soccer team won the World Cup in 2006. The entire country of Italy was holding their breath at the time because they won with a penalty kick. And the reason that was significant was because Italy had lost at least one very important match by missing a penalty kick prior to this. And so everybody in the country was thinking, oh my God, he's going to do it again. Well, he got the penalty kick. Of course, they won the World Cup. Their secret, which came out later, was they spent several months in Milan at the Mind Room, where it was a sports psychologist who did biofeedback and neurofeedback, and they trained these athletes to be able to get into this state of the flow, where they would visualize making these penalty kicks and would be going through. And that set up a whole new business in sports psychology. Now the Canadians and most of these countries now are using this concept of using sports psychology, integrating neurofeedback with biofeedback. Alpha theta training, shifting over to that again. That's a separate specialty. I do it in my office. It's not high frequency, it's low frequency training. Put the sensors in the back of the head, and I have you close your eyes, and I walk you through a visualization. If it's for alcohol, I would say I want you to visualize you going to a place where you would normally go to have a drink, and then you walking by it. Or if you're driving to a place, visualize yourself going someplace different. And really get that feeling, what it feels like for you to be alcohol-free. It's about a 5 or 10 minutes walk through a visualization. And I say, just hold on to this for a while and now listen to these tones. And the tones guide you into 6 to 9 cycles per second in the state of reverie. In the state of reverie, the brain begins to shift. It begins to somehow unconsciously work through traumatic issues in a safe way. Now, this brings up what's called alpha blocking. You and I, if you're not traumatized, you open your eyes, you should have very little alpha in the back of your head. You close your eyes, your alpha should go up at least 50%. If you're somebody who is a great visualizer, a great artist, a great athlete, it may go to 150%. But if it only goes to 20%, you have what's called alpha blocking. Your brain is protecting you from going and reliving that trauma. If you close your eyes and just relax a bit, your brain is going to go to sort of the lowest elevation. And if you have a trauma, your brain will go and take you to that trauma, and your brain doesn't want to go there, so it will block it. It will just block that alpha. So what we're doing here is safely releasing that alpha up, and it also works for PTSD. The brain somehow unconsciously figures out it's okay to bring up this alpha without going back into the trauma. And these people most people very relaxed with less craving for alcohol. About 30% of the people who go through this kind of protocol have an aversion to alcohol. They actually get sick if they drink. And this got discovered because Peniston was working with veterans at the time. He was working initially with alcoholics, and a lot of these veterans had PTSD, and they resolved their PTSD. So he did a second study on PTSD, and he found MMPIs were normalized, and those who did not do the alpha theta, they relapsed on alcohol. You can also do brain brightening. As you get older, like I said, your peak alpha frequency goes down. It is possible to put a sensor on the top of your head and train that peak alpha frequency to go up. You need to do it 4 times a year, though, because it's still going to be going. The cart's going to go down the hill regardless. I did a study of my work in 2014, presented at a conference for those who had 12 or more sessions of neurofeedback, the particular one in Neurooptimal. 74% had a very significant response. I was doing a study comparing it with Davidson's 6 emotional styles. 75% improvement in resiliency, outlook, self-awareness, social intuition. 50% improvement in sensitivity to context and attention. 75% less worry. Half of them stopped worrying about pleasing other people, and half became more assertive. The most consistent finding in my work: less drama in the face of stress, faster recovery from stress, healthier, more stable baseline, greater self-awareness, and better sleep. And of course, there's always clinician variables. I am part of the machinery. I am part of the circuitry between me, the client, and the machinery. Here's a study that was done. A warm, confident trainer successfully taught 20 of 21 subjects to raise their finger temperature. An impersonal trainer succeeded with 2 of 22 subjects. So, can a clinician only train what he or she has already learned to do? Probably. You would be unlikely to hire a piano teacher who could not play the piano. This is kind of a convoluted sentence, but I say this, that something I discovered early on is, as a psychologist and psychotherapist, that it always stood out to me why somebody could come to see me who had anxiety, depression, and 10 to 12 sessions of talk therapy, good CBT, they're good to go. They just resolve the issue, they're very happy. Some people come to see me that have 10 to 12 years of talk therapy and they're still processing the same stuff. So I did an informal survey many years ago, and I found most of those individuals had a history of head trauma, head injury, or major stressor that tweaked their brain in a way that there was suppression that was happening. The brain could not integrate what I was doing with psychotherapy. So when I added neurofeedback, things start to progress. And this is one of the hidden things in my field, is that we don't take in consideration you can have a brain that's stuck. And it's not your work. It's not the quality of your work. It's that person's brain is stuck. It's been suppressed in certain areas, and it fails to integrate what you're trying to do to them, or with them, or for them. You put somebody into neurofeedback for a series of sessions, they go back to talk therapy, therapy really begins to move. And I've seen this countless times. Frank Duffy, professor of pediatric neurology, Harvard Medical School, wrote, "In my opinion, if any medication had demonstrated such a wide spectrum of efficacy, it would be universally accepted and widely used. It's a field to be taken seriously by all." Why is it not well known? Until recently, it's not been taught in graduate schools. Technology is expensive. It's expensive stuff to buy. It's outside of the medical model. It's a different paradigm. It's the body healing itself. Insurance rarely reimburses. It's really kind of crazy. I try not to deal with insurance companies at all with this. Medical textbooks list neurofeedback as experimental, or will say the results are inconclusive. Now, in my practice, I do lots of other things. I had HRV training, heart rate variability, alpha stem, HEG, and EMDR. You're familiar with heart rate variability training? It's what every clinician would be nice if they had that in their office. It's not very expensive. You train to increase the beat-to-beat variability of the heart. And you can do that by teaching 6 breaths a minute. If you have computer assisted with you, watching the screen, you can see that wave going up and down. And then they can practice in your office and demonstrate that they can do this. There's plenty of home trainers. They're cheap. You can have apps in the phone. Cost about $4 or $5. The problem is patient compliance. You have to get people willing to do this. Studies show that if patients follow this recommendation consistently, 20 minutes a day, you will reduce anxiety, reduce depression, reduce PTSD, reduce drug cravings, reduce IBS, reduce chronic muscular pain, headaches, asthma, hypertension, fibromyalgia. These are all peer-reviewed studies. But again, compliance is an issue. HEG, Herschel Tuman, one of the original founders in biofeedback, started the biofeedback clinic in 1980 in Los Angeles, trained hundreds of people in biofeedback. One day he read an article saying, oh, you know, there's you could probably learn to train the cerebral blood flow of your brain. So he went in his lab and he put this HEG together. This beams in an infrared light and across the cranium, and there's a computer chip that reads the color red. You want to get more red. You get more red, you start flying over lakes and mountains, you start moving the software. When do you want more red? Well, the only way you're going to get red is get more oxygen, more blood flow. Cerebral blood flow is extremely important in the brain. You bring in more blood and oxygen in the frontal lobe, the whole frontal lobe begins to improve, functions better. You'll clear mental fog, increase motivation, improve memory capacity, control impulses. He believed, there's no study that demonstrates that, that's more efficient and more effective than EEG training for most brain disorders. Now, I haven't really done it to that extent to prove that to myself because mostly I do neurofeedback. However, every once in a while I do the HEG, and it really makes a difference, particularly for migraines. You can really get migraines to resolve quite well with that. He also used a lot with autism. If you can get autistic kids to use it. The entire country of Thailand uses it as the primary treatment for autism, HEG. Now, because I have compliance issues with my clients, and I'm sure all of you do too, I use the Alpha Stem, been an Alpha Stem distributor for 7 years. And this actually, it's an incomplete picture, but there's 2 wires that come out, little ear clips, alligator clips, you put it in the earlobes. And it's a 9-volt battery, you turn it on, and it'll produce low level of electronic pulsing stimulation to the brain. It's been out for 40 years. It will increase alpha amplitude and increase alpha symmetry in the frontal lobes of your brain, reducing depression. It'll reduce your high beta, which is your anxiety. It will increase your beta endorphins by 200%, which is your brain's natural painkiller. There's no adverse effects. Why would you not want to do this? I use it because to get people to do homework is very difficult. Even if they agree with you, it helps. So with this, you can put it on, you can surf the internet, you can wash dishes, you can talk to your spouse, you can watch a movie. Just live your life. Almost 100% compliance with the Alpha Stem. They run retail now about $800. What I do, I have a bunch of them, so I lease them out clients to buy, and I get a 75% response rate. 75% of my clients will say, this has helped me, and about half of those wind up buying it from me. It's a great adjunct to talk therapy. It's a great adjunct to neurofeedback. I do EMDR, particularly for people who have had car accidents, TBIs. That's because a lot of people were traumatized at the moment that they were injured. Case in point, a woman was getting off the freeway here in Santa Barbara. She looked in the rearview mirror. Here was a car coming. She go, uh-oh, and she got a whiplash. And she had all the symptoms of TBI. So the neurofeedback helped really, really well with that TBI, but there was still something missing. So I did this, the EMDR with her, because she was still reliving that car coming behind her. She still had a hard time driving. And that takes about 6 sessions. So you combine the 2, it's really, really potent. Then I have what's called a tranquility room. In my second room, I have 2 treatment rooms. I have this relaxation chair. It sits on top of a motor, and it moves you around, quiets down your entire brainstem. Women over age 50 love this machine. They really, really like it. They want to come back all the time. And what I do sometimes is I'll do neurofeedback on this chair. And sometimes I'll spin them around at the same time. And sometimes I'll use the neurofield. Don't use that a lot. But the neurofield is pulsed electromagnetic frequency. These are the 4 coils. Usually I put it on the gut. There's a particular setting you can put on the gut that really improves functioning for IBS. 95% of your serotonin comes from the enteric system. So there's something about making people feel better about stimulating the gut. There's a couple of books, Conquering Concussions. You're going to have a copy of this. If you want to have an interesting read about the history of neurofeedback, I strongly recommend this book, Symphony of the Brain by Jim Robbins. And here's the research articles, ISNR, 2 major organizations, International Society of Neurofeedback and Research, and American Association of Applied Biofeedback. And you're welcome to visit my office for a free demonstration. Call me up, give you a free tour of my office. There's my office. And even give you a free neurofeedback session. Questions? Yes.
Did you say something about Thailand and autism?
Yeah.
Are their rates better? Do they have better outcomes for children?
No, what happened was that the prince of Thailand had a lot of autism in his family. And he read an article that Herschel Toom had written about autism and HEG. So he sent an emissary over here to study it, and the guy said, it looks pretty good. So he brought it back to Thailand, and it worked.
So they have
And
better outcomes in Thailand than we do.
they're more open than we are. They're more motivated. So every facility in Thailand for autism, this is what they use as HEG as it's a major part of it. And the kids even train each other on it. It makes significant improvements for autism. Yes?
Recently discovered that sleep disorders and sleep issues are a very common symptom resulting from TBI.
Yeah.
And so can you talk a little bit more about the effectiveness of neurofeedback with sleep issues?
Neurofeedback tends to resolve almost all of the symptoms of TBI, regardless of what they are. You can pretty much reset the brain almost to original specifications, unless there was a part of the brain that was just really fried. I mean, that died in the process. I mean, I would say it's on a continuum, that the mild TBIs remit really fast, really well. Those who are like in a wheelchair and are really struggling, that would take a long time, and they're not going to get 100% back. And in terms of sleep, that's variable. It's hard to say. It's really hard to predict.
The sleep issue that I'm looking at with this particular client is non-restorative sleep. So there isn't any
Yeah.
difficulty falling asleep, there isn't a difficulty
Yeah.
with waking.
They're not getting sufficient enough delta waves at nighttime.
And do you see effectiveness with
Yeah.
neurofeedback with
Yeah.
correcting that?
Every brain's a little different, and the response is going to be a little bit different, but they tend to be positive.
Thank you.
Thank you so much.